Good evening, everybody. Hope you all are doing well and enjoying your evening. My name is Dr. Nate Lighthizer, faculty member optometrist at the Oklahoma College of Optometry in Tahlequah, Oklahoma. It is my pleasure to share the virtual stage with Dr. Bradley Grant. Not the first webinar we've done on ERG here and talking about the technology. Bradley, welcome. Looking forward to it, buddy.
Absolutely. Thank you. Is this 3 or 4? They're starting to blur. I'm
Yep.
incredibly flattered to get to share the stage with you that often.
Yeah, so it's awesome. So we're excited. I know we've got some that have the device already, many that are looking at this technology. We're going to talk about the latest and greatest in research, a few cases, how to incorporate this technology in the practice. What are the upsides? What are all the positives with ERG in the exam lane? So this is, you can see the device right there, handheld, to take it right to the patient. It's just tremendous. It's evolved tremendously over the course of the last 10, 15, 20 plus years. ERG, that's what we're going to talk about this evening. And Dr. Grant's going to kick us off right away with a quick case here.
Right. I really feel like we're starting somewhat with the end in mind with this case to where we're talking about two different patients is what's the big value that ERG would bring to our practices. And it's that differentiating when anatomy is the same, right? When the retina is telling the same story, who do we know we should be more concerned about based on functional findings? And so if you go to the next slide, patient number 1 is a patient that most of us on this call probably saw today, or at least have seen this week, maybe multiple times. 63-year-old male with mild diabetic retinopathy, meaning just microaneurysms only, been diabetic for many years, really not any significant reduction in visual acuity, and we don't have OCT images on this patient, but just very mild macular edema. Next patient, very similar fundus findings. If you all can tell the difference with the size of the fundus images between the two retina, you've got better eyesight than I do. But basically, mild diabetic retinopathy, very similar demographics, a little bit higher A1C. If you remember, patient 1 was in the 6s, but almost identical in terms of the overall anatomical staging. So next step that I know Dr. Lighthizer and myself both do with patients with diabetes, but also especially with diabetic retinopathy, we're going to get some additional testing to see if there's some functional changes. And on ERG, specifically the RETeval device and the DR protocol, this is what the printout looks like, and it's going to give us a DR score. And we're going to dive into this tremendously tonight, but it's going to give us a DR score that's going to give us the ability to calculate the risk of progression. And when we say risk of progression, we're talking about progression to sight-threatening retinopathy, meaning neovascularization, macular edema that needs treatment, truly changes in vision, truly functional change in vision. So this is an example of a printout. We'll go through many more of these tonight. Also at the bottom, we'll dive much deeper into the assessing progression risk and the different levels there. So we go to the next slide based on
and Bradley,
these two
don't you
patients.
think? Don't you often think, our job when as optometrists, we're not sticking the needle in their vitreous. We're not doing intravitreal injections. We're not doing retinal lasers at this point. We're not doing vitrectomies. A lot of times our job in retina, whether it's diabetes and diabetic retinopathy or macular degeneration, is risk assessment. How
Exactly.
likely is this patient going to progress? How likely are they going to stay stable? And the more information that I can have that helps me make a better decision. Is this patient going to progress? Are they likely going to stay stable? That's a win for us as the decision maker and the guider of this patient here.
Right. 100% risk assessment, and dovetailing that into patient education based on referral patterns and follow-up patterns. If we look at these two patients, again, very different in terms of their DR score. And the translation for that is very different in terms of the function of the retina. So anatomy may look very similar, but there's two very different stories being told by the functional assessment of the retina. And in one case, patient 1, who happen to have the better A1C. Their DR score is 17. We'll talk about how that really keeps a very low risk profile for them moving forward. But the patient too of DR score of 27 is a tremendous risk, and actually a tremendous risk for having sight-threatening retinopathy within a 12-month period. And so this should 100% change our approach to the care of this patient, to the conversations we're having, to the information we're sending to their primary care and endocrinologist. So having functional data can completely change our outlook and practice patterns.
Yeah. So, looking at structure and function, it's a great case. I mean, that's a really, you have basically identical looking retinas, identical looking structure, identical looking OCTs, but yet, Bradley, the function is nowhere close to identical when it comes to the ERG. We now know who we need to educate better, follow more closely, maybe recommend nutritional supplementation, et cetera, et cetera, et cetera. It really drives home the structure and function in ocular disease. And I always ask this question. So I want you guys to appease me if you're on this call. I want you to grab your phone real quickly, and I want you to scan that QR code. And that's going to open up my Poll Everywhere page. We only have one question tonight. It's on the next slide. And it's a very, very simple question. So again, open up your camera, scan that QR code. It is not going to ask you to download anything. It's not going to ask you to sign up for anything. It's going to open up my Poll Everywhere page. Again, if it asks you to sign up for something, I want you to just hit skip for now. Just skip for now. And it's going to ask you this question. Okay. It's going to ask you, do you think testing structure and function in our ocular pathology patients is important? Okay, I'm going to go back one more slide just so you can see the QR code. Again, scan it with your phone. Little yellow tag will pop up. Click that, brings up my Poll Everywhere page. Again, don't download anything. Don't sign up for anything. And again, it's a very simple question. In your glaucoma patients, your retina patients, your optic nerve patients, do you think testing structure and function in our ocular pathology patients is important? We've had 44 of you respond, and 98% of you think testing structure and function is important in our ocular pathology patients. We do this all the time. In glaucoma, you do this with your OCT and looking at the nerve, you're looking at the structure and visual fields. For all these years and decades in glaucoma, you are looking at function as well. Visual acuity is a form of function. There's a lot of forms of functional testing, but they have limitations, as we'll talk about. But the point is you guys believe in structure and functional testing there. So we do a lot of structure. When I ask, Bradley, historically, what's the two most common ancillary tests that you would do? I'm talking not in the last couple of years. I'm talking last 5 years, 10 years, 15 years. When you did your exam, your dilated exam, and you got a couple of additional tests, ancillary tests in a patient with diabetes and diabetic retinopathy, what were they?
Fundus photos always, and again, depending upon if we're talking 10 years OCT prior to that. Yeah. Maybe referring for fluorescein angiography. But
it's
all
photos.
All based on photos, right?
Photos, which look at structure, OCT, which looks at structure, and your DFE, when you're looking at the back of the eye, that looks at structure as well. So that's a lot of structure, and let's pair that with some functional testing as well. Well, there's a variety of functional testing options. I mean, you can look at all of these different functional testing options. I'm going to go back here. All of these are looking at function in one way or the other, but they are dependent on the patient. They are subjective. They rely on that patient responding, and they have limitations because of that and other reasons as well, which we'll talk about in just a little bit. So yes, you're going to check visual acuity, but that's a very tiny center spot on the retina, the fovea, and you can have a lot of other issues going on in the retina, and yet their visual acuity is relatively good. Contrast sensitivity, color contrast, visual field, Amsler grid, hyperacuity perimetry, dark adaptation, again, all may be used occasionally here and there, but again, Bradley, in private practice, you're not doing these on a routine basis in your diabetic patients, I bet, are you? Is that correct?
No, I mean, with the exception of visual field testing on those with already known retinopathy. No.
Correct.
Yeah.
That's it. And visual acuity, obviously. The point here is when you think ERG is a great functional test. And how does it differ from the other ones? It's objective. This does not rely on the patient. They don't have to click a button. They don't have to give you a feedback. We are flashing lights in their eyes, and it's objectively telling us about retinal function. Is the retina functional, or is there some dysfunction there? And we'll talk about what that means here in just a little bit. So it's objective functional testing. Remember, this is a flash of light. It is a flash of light, flashes lights in the eyes, and because of that, this is really a global test of retinal function overall, from top to bottom, left to right, superior, inferior, nasal, temporal. How is the retina functioning? Okay. And again, if you want to dive into the electrodiagnostics weeds, depending on which part of the waveform you want to look at, whether it's the A wave or the B wave or the C wave, again, you can ignore all that I just said. It's photoreceptors, intraretinal cells, or ganglion cells. But again, just remember, because it's a flash of light, it should make sense. If I flash lights in your eyes, that flash of light's going to go up, down, left, and right, central, mid-peripheral, and peripheral. So the ERG is an overall test of global retinal function. To be a win, it's got to be, it's got to change things. It's got to change the way I think and the decisions that I make. Does it do something our other technology doesn't? The answer is yes. This is looking at function objectively. Okay, we just showed you some functional tests. Many of them we don't use a whole lot, but they're subjective. This is looking at function, and it does it objectively. We'll provide clinical information that will impact the treatment. Hopefully, we show that to you over the course of the next half hour or so with all of the latest research going. This affects our decision making. I need to see Mrs. Jones back in 4 months instead of a year. I need to see Mr. Jones back in a year because all is stable, looks good, and I feel great about it, and I can educate him well that his A1C is doing well and his retina is functioning well with that ERG, and that's what that showed me there. So provides us a lot of clinical information that the OCT does not, the fundus photos do not. Again, it doesn't replace those, it pairs with them beautifully. Can it be incorporated into our office? I work in academia. So again, we do a lot of different testing for educational benefit for our students and residents. So Bradley, I'm going to kick that to you. You're in private practice. Incorporating this, you worry about space and patient flow and staff, do you not? Tell us about the handheld RETeval.
100%. And as with any new, whether it's instrument, technology, specialty we might be doing in our practices, there's a certain amount of planning we want to do with integration. I think the most valuable aspect of the RETeval device is its portability, right? So we're not using a specific footprint of a pre-testing room, right? We don't have to wait on somebody to be done with an OCT to do it. The staff who is doing the workup with the patient grabs the RETeval device and then performs the test in the exam room on the patient. And so the device travels to the patient instead of the other way around. And so specifically when square footage is at a premium, this does not make you have to decide between what are we coupling it with and what are we maybe going to, where we're going to find some log jams in terms of patient flow. So short of training your staff to perform the test, which is very straightforward as well. It's a very easy incorporation into clinic flow, which really is everything, right? Nowadays, how many in private practice, we're talking about profitability, how many patients can you see and see well and in an efficient manner is part of every formula that we use.
The interesting question is another interesting question is the next one, is this standard of care or leading edge? 5-6 years ago, this would definitely have been cutting edge, leading edge. You were one of the early adopters. If 5-6 years ago, 7 years ago, you were bringing this into the practice. And I think as you'll see with the literature coming up here in just a little bit that we're going to show you, this is getting closer and closer and closer, if not already standard of care functional testing in our patients with diabetes and diabetic retinopathy. So this is amazing technology. And again, because of the Mary Tyler Moore Initiative and the American Academy of Ophthalmology and numerous other literature that's out there that says this is really your best predictor whether your patient is going to progress or they're going to remain stable. So I think we're getting closer and closer, if not already there, for standard of care. Patient friendly is incredible. I've been amazed, and I've been doing ERG since 2009. in clinic, and I've had about 5 different systems that we've had, and it's went from, probes going into the eyes where they were dilated and we're sitting them in a dark room and dark adapting for 45 minutes in a big instrument, to now walking this to the patient with them right in the exam chair, undilated testing where, for your diabetic retinopathy protocols, where you don't have to dilate them, we don't have to dark adapt them. And I have been amazed how impressed patients have been when you can bring a handheld device right to them. And when you explain it, Mrs. Jones, this is have you ever had an EKG before? This is the EKG, and all patients, by the way, have had an EKG, or they know what an EKG is. They just know. People just know what EKGs are. And I said, they hooked up electrodes to tell you how the heart is functioning, how is it firing, how's it working, basically, and hopefully it's functioning well. But that can help to detect that there are issues or some dysfunction with your heart. And I always hold it up. This is the EKG of the back of your eye. This is the EKG of the retina. We call it an electroretinogram. And we're going to hold this up here, put some electrodes right in your lower eyelids. Nothing's going to touch your eyeball at all. And we're going to flash some lights in your eyes for about 1 minute. 1 minute in the right eye and 1 minute in the left eye. And it's going to tell us, how's your retina firing? How's your retina functioning? Basically, how's your retina working? And hopefully that all comes back normal. That's awesome and things are working well. But if not, we can follow you more closely and we may have to change a few things to get that retina functioning well. So this is the EKG, the back of the eye, and it's been amazing to see people. That is really cool, doc. The way they look at you, like, man, you're on cutting edge, and my doctor has got the latest in technology. So I think it's incredibly patient friendly, profitable, and or practice building. Again, I'm in academia, Bradley, so maybe disqualified from that one. So I'm going to kick that to you again, buddy.
Yeah, I'll do just some rapid fire bullet points on that. And I've seen some questions come across. I'll try to answer some of those with some rapid fire here. So there is a CPT code for it. This is not an IPL treatment where it's an out-of-pocket expense for the patient, 92273. Average reimbursement is around $115. So very profitable CPT code, and we're going to get into the different ICD-10 codes that you can bill for it. It's not a mutually exclusive code in the sense that it can be performed on the same day as other structural testing as well as other functional testing. So you could actually bill on the same day with a 920 or 83 visual field if you felt you needed to do that, but also you can bill it on the same day as an OCT, whether that's a nerve or a macular OCT. So it does not negate the use of other testing on the same day. It doesn't have to be an isolated visit. From a practice building and practice differentiating standpoint, Dr. Lighthizer just touched on it. There is nothing more valuable, in my opinion, than a patient being able to notice that you are leading edge, that you are caring for them in a way that they've never seen, and able to explain it to a level that they've never heard. Right. I've never seen someone that has not been impressed with the technology. And I think that helps from referrals, whether that's patient to patient, patient to family, just primary care referrals, right? When you're raising your level of technology, you're raising your level of care, that always results in practice growth.
All right. So, again, looking at it, we've kind of touched on all these points already, impactful and comprehensive. You're getting functional data. We'll go through the printouts in just a second. Very easy to integrate because of that portability that it is there, that you can bring it right to the patient. Minutes. We're not, again, putting electrodes on the actual ocular surface like we were 15 years ago with other devices there. Again, nice training, accessible. Again, you can see the pricing there, which I'm sure we'll talk about a little bit later there, but portability to me is key. Smart investment. You talked about the 92273 as well. Again, other functional testing. We mentioned this already. Best corrected visual acuity. Yeah, you're going to do it on every single patient, but that's what it's testing. That central 2 or 3 degrees, there's a lot of retina out there that can be dysfunctional, not involving the central 2 or 3 degrees. So that's not your best test for overall retinal function. OCT, wonderful. I hope all of you have OCTs and continue to utilize OCTs in your practice. It's looking at structure right there. Again, your 24-2 visual field or your pattern ERG or a multifocal ERG are looking at more central retinal function. You're going to testing in this area. And the flash ERG is looking at everything. Again, top to bottom, left to right. Overall, How is the retina functioning from a global perspective? And that's what we want in retinopathies, diabetic retinopathy, among many other things as well. So let's take a look at the printout. You may think, golly, ERG, Nate. I remember that from school in 2002 and 2011 and 1998. And, I stayed out of that room in the back at school where there was no windows and who knows where they were going to attach electrodes to me. So I don't remember. I'm overwhelmed with ERG. Well, don't overthink this, okay? We're looking at function, and there are waveforms, as you'll see down here, bottom left and bottom right. And we're looking at a couple of things that we'll describe in just a second. But don't overthink this, okay? Like the EKG. You guys you're not cardiologists, you're not heart specialists, and neither am I. Neither is Dr. Grant, but you can probably recognize that EKG looks a little bit better than this EKG. There's nothing there for that one. That's flatline. And the reason you know that is there's no peaks, okay? So the strength of the response and the speed of the response is much less, much different. Flatlined here compared if I go back a slide on that normal sinus rhythm EKG. The ERG is very similar. We're looking at two things here. We are looking at the strength of the response and the speed of the response. Now, I want to be very clear. This is the number 2 or number 3 protocol that we do. The beauty about that handheld device is you can choose the protocols. I want to do the diabetic retinopathy assessment protocol, which is the number 1 protocol that we do. We're going to talk about that here in just a few minutes. Okay, the DR assessment. That's the number 1 protocol. And the second most common protocol is probably the Flicker 16 that you're looking at here. And this is for other retinopathies, hypertensive retinopathy, retinal hemorrhages, not diabetic related. If your patient is not diabetic, but yet you still want to get a nice picture of how's the retina functioning, how's it working, you can look at the Flicker 16. So that's what this is here. This is a Flicker 16, and there's 2 main things I'm going to look at. Again, here's the waveform down here in the right eye and the waveform down here in the left eye. I want to know about the amplitude, which is the strength of the response, and the implicit time, which is the speed of the response. I always say you want your ERGs like you want your athletes, strong and quick. Strong and quick. You want your athletes strong and quick, and you want your ERGs strong and quick. The strength is the height of the peaks. Okay, the height of the peaks here. Look how, these peaks, the bigger they are, the better. You got 1, 2, 3 peaks in the right eye and the same in the left eye. The bigger the peaks, the stronger the retinal response, and that is a good thing. That's the strength. The speed, that is how quickly these peaks are happening. Again, I want these quick. You want the retina responding quickly to those flashes of light. There's actually kind of a little cheat box here, a little cheat rectangle, and this is earlier software. The current software has all of for every peak where they should land. So this is where the first peak should land, in this little rectangle right here. And if it's below that, that's weak. If it's behind that or to the right, that's going to be slow. Again, we want this to be quick, quick, quick. So you can't know what abnormal is until you know what normal is. And you take a look again, right eye and left eye, very, very normal waveforms. Again, I haven't even talked about any numbers yet, but it looks very, very normal. So that's what normal is. What does abnormal look like? It's going to look like that. Okay, and notice here, when you look at those waveforms, don't even look at the numbers yet, just those waveforms, notice how they're both low and slow. Those peaks are below where they should be landing, and they're to the right of where they should be landing. This first peak right here should be inside that green box, and the second one should be inside that orange box. They are low and slow. That's what we're looking at when you're evaluating this waveform, okay? But you may say, Nate, I want some numbers. Give me some numbers on this. We all like numbers. On our OCTs and our visual fields, give us numbers. So let me go back to the normal one, okay? Let me go back to, I'm going to get that sinus rhythm out of the way there. So there's your normal one. Peaks look good, don't they? Those nice high peaks, quick, landing in the box, awesome. But give me some numbers. And notice we'll start with the implicit time. That's the speed of the response. I call this the 100-yard dash. If you enter a 100-yard dash, do you want a big number or a small number for your time? And the answer is you want a small number. 100-yard dash, the smaller the number, the better. I look at these percentages here, and from 0% to 100%, the smaller the number, the better. The smaller the number means the quicker the retinal response, and I want a nice, quick retinal response. So the take-home point is the smaller the percentage, the better. Right eye and left eye. Okay, so that's the speed, the implicit time. The amplitude is the strength. Think of that as a weightlifting competition. If you enter a weightlifting competition, do you want a small number or a big number? You want a big number in a weightlifting competition. So for the amplitude, this percentage, the bigger the percentage, the better. Unlike the implicit time, where the smaller the percentage, the better. This is the bigger the percentage, the better there. So that's how I look at those numbers. That's what we look at over time as you're doing this once a year, then a year later, then a year later, or maybe it's twice a year in a patient that's higher risk. You guys are the doctor. You'll know how often to do this, but that is very, very normal based on those numbers. Let's go back to abnormal. Qualitatively, you saw it was normal. How about quantitatively? Look at those numbers. It really couldn't be much slower. Look at that. And over a minute, this flashes two different types of brightnesses. That's the 16 and 32 on the left there. But notice our time is 100 and 100. That's as slow as it gets. I want a small number, and we're getting a huge number for the time. In the weightlifting competition, 0%. This patient can't even get the bar up in a weightlifting competition. But this is a slow, this is a weak retinal response. And this retina, Bradley, anything to add? This retina is struggling, isn't it? High risk.
No, just your association with weightlifting. It's giving me some negative flashbacks. So, I mean, I agree with you on the retina, but I just identified too much on that 0% on the bar. So we'll keep moving. Yeah.
Yep. There you go. So that's how you interpret these. And again, assessing structure and function, it's objective. We talked about this already. It's going to help you detect who's functional, who's dysfunctional. It's going to help predict progression, manage, monitor. So let's talk about, is this leading edge? Is this standard of care? Again, it is the journey to standard of care has been moving and moving and moving and closer and closer and closer over the course of the last, again, 5 to 10 plus years. This has now been added to the American Academy of Ophthalmology preferred practice patterns for diabetic retinopathy. The American Academy of Ophthalmology has recognized the importance of functional testing and the importance of ERG. It is in their preferred practice patterns. That is a big deal. Huge deal. And again, I mentioned earlier the Mary Tyler Moore initiative. Mary Tyler Moore was a diabetic, a brittle diabetic, and they have a big initiative, sponsored clinical trials by the Diabetic Retinopathy Clinical Research Network, and they have recognized the potential that this device has in measuring retinal function and to guide our clinical decision making. Again, who's more likely to stay stable and who is more likely to progress through the stages of diabetic retinopathy. So those are two very big things here. And again, we talked about this earlier, kind of your three most common protocols. The diabetic retinopathy protocol, as you can see on the left, it's going to be by far your number one protocol, the DR assessment. When you have the device and you enter in the information, you select your protocol, the DR assessment is going to be your number one protocol. And then your general retinal health, look at all those different conditions where you may run that Flickr 16 that I just talked about. Again, from hypertensive retinopathy, don't forget your visual disturbances, decreased vision, color vision issues. Doc, I can't see as well at night. Like I said, color vision issues, night blindness, unspecified visual disturbance. If you get an OCT to figure out things, you're looking at structure to figure out things. Let's look at function to figure out things as well. And then don't forget about your optic nerve. Again, whether it's glaucoma, other disorders of the optic nerve. Again, we'll get there more in just a little bit there when we talk about the photopic negative response. So diabetic retinopathy. Again, we've kind of covered all of this already. We're looking at implicit time. We're looking at amplitude. That's the speed and the strength of the response. It looks at pupil size. When you do your diabetic retinopathy assessment protocol, the number one protocol that you're going to do, you cannot dilate them. They cannot be dilated because you're looking at pupil response. Part of its calculations, the software is looking how well does the pupil respond to a dimmer light and to a brighter light. So you cannot dilate them for that protocol, which is great. I don't have to dilate them. I don't have to worry about that. And the patient's age. So those are the 4 things that are factored in when it comes to the DR score, the diabetic retinopathy score in the DR assessment protocol. So I encourage you all to look at this study published in Ophthalmology very recently in the summer of 2025, looking at these patients with moderate to severe NPDR, testing them with ERG, and looking at 56 different parameters over 4 testing modalities, from the ERG to fundus photos to OCT angiography to fluorescein angiography. So it looked at all of these different parameters in these 4 different tests and said, what's the best parameter for predicting progression? How likely are these patients going to progress? And here's the study here, predicting progression to vision-threatening complications in diabetic retinopathy, macular edema, neovascularization, vitreous hemorrhage, etc., those vision-threatening complications. And again, fundus photos, OCT angiography, fluorescein angiography, and ERG, 4 testing modalities. And within those 4 testing modalities, 56 different parameters. There they are, 56 different parameters. I'm going to pause here for just a second to let you guys digest this slide. Notice a good chunk of them are in blue. At the bottom, that's your fluorescein angiogram, looking at a variety of different parameters within that ultra-wide field fluorescein angiogram. Just above that in orange is your OCT angiogram. Just above that in green are your different parameters in the ERG. And at the top there are your fundus photos, standard fundus photos. So there's your 4 different modalities in red, green, orange, and blue, the parameters within them. And you can see the ones that were statistically significant in predicting progression in these patients with moderate to severe NPDR, non-proliferative. And you all know a p-value less than 0.05 is significant. That's 1 star. And as it gets to 2 stars and 3 red stars and 4 red stars, it's getting more and more statistically significant. Okay. If it was not significant, meaning not predictive, it's going to have an NS next to it. And guys, just take a second to digest in the blue at the end and the orange and the green and the red, which ones. Again, you want to see stars behind them. And the more stars that you get, and we made it easy with the triple red stars and the quadruple red stars, that was even more statistically significant. And the most highly statistically significant indicator of progression in these patients is the DR score. Bradley, I want to get your thoughts. Any thoughts on this study?
So, I think it's the next slide that goes over the results. But what really just always jumps out to me is not even just that the ERG DR score is superior in assessing function, but multiple different parameters of that are better.
Look at all the red. Look at all the red in there, right?
Yeah, multiple levels of predictive capability supersedes anatomical prediction of risk, right? And up until, speaking for myself, a couple of years ago, for better part of 2 decades, I went solely on anatomical findings. If you jump in just 10 seconds back to you don't have to go back to slide, but the Mary Tyler Moore Initiative, why we're establishing new protocols, ETDRS, DRSS, right? Those are all anatomical grading systems. They're all multiple decades old, but they do nothing about function. And this is basically turning that on its face to say, look, we need to be looking at this. This is a better predictor.
Yep, absolutely. And you can see, again, as they kind of summarize this data here, the strongest predictor of progression. You can see, again, the numbers matter. The higher the number with the DR score, I always say, like, this is your golf game. The higher the number, the worse it is. The lower the number, the better it is. And we'll go over that in just a second. But you can see the risk of progression with the DR score and where it's at compared to OCTA, the foveal avascular zone, and fundus photos. And ultra wide field. And again, this really goes back to it's why we already talked about interpretation of this. We've already went through interpretation. We've already went through, looking at the waveforms in the right eye and the left eye. And you look at this printout on the bottom left. I know it's kind of small, but look how low those peaks are, how weak those peaks are. Again, the strength is super weak here. But I love with the DR protocol, the most common protocol that you're going to do, it gives you this number, this overall score. Again, the DR score. Where does that come from? The amplitude, the implicit time, the pupil response, and the age of the patient factors all of that in, and you can see where these land. If it's in the teens, awesome. So I tell our students and residents and our patients, if it's in the teens, I consider that normal. If it's in the low 20s, kind of between 20 and 23, that is borderline, starting to become abnormal. We're starting to have some risk. It's approaching limits. It's approaching outside normal limits, and I'm going to watch that more closely. And you get 23.5 and above. And again, based on this data published last summer, you can see the risk of progression in 6 months and in 1 year in these patients with moderate to severe NPDR there. So that's how we use this protocol. I look at the number, I look at the waveforms, I look at the amplitude and implicit time numbers quickly, but overall, I start with the DR score and I end with the DR score when I'm interpreting these. And again, that's how I'm assessing progression or risk. We just went through all of this already right there. So,
and Dr. Nate, would you agree that the DR scores that you find that are, we'll call it north of 22, they're not one-offs, right? We see them all the time.
All the time.
They're very routine part of clinical care. So it's not, looking for something that's incredibly rare. You're going to find elevated DR scores the first week that you're starting to implement this testing.
I completely agree. Now, fortunately, we see more of ones that look like this, which indicates stability, and that's awesome. But it's not going to be 1%. It's not going to be a small number where they have a DR score that's 23.2 or 21.7. Or I'm watching a lady right now every 4 months, and her number is 25.2, 25.8, 24.9, 25.4. And we're just watching this because when it's 20, it's 25. Look at her risk of progression. Okay, look, it's high, and we're watching her very, very closely on that. So that's the value of this. Again, I hope it looks like this. You take a look at that report on the left, immediately, DR score 18. Wonderful. Awesome. It's 19.9 or less. Risk of progression based on that study from last summer, 0. And look at those peaks. Awesome. Strong peaks, strong peaks. It's quick. Everything's in the green. One last glance at the DR score, 18.0. We love it. Awesome. And then all right, look at this one. This is fairly regular, as Bradley just said, isn't it? This is kind of the, you get this quite often and go, this is actually one of my patients, and you take a look and you go, that's 21.6. Are those peaks more low or more slow? Are they more low or are they more slow? And they are more low. Those peaks are below where they should be landing. And you can see the amplitudes are weak. That weightlifting competition is weak there. DR score elevated. Let's watch this fairly closely. Risk of progression in that patient profile versus this one. Now we're 23.7, super weak. Super low on those waveforms. Again, you can see we're at 0% in the right eye and the left eye for the amplitude. Again, DR score elevated, higher risk of progression in this patient there. So higher risk, watch, maybe it's 3 months, educate them well, show them this, blood sugar, blood pressure, exercise, nutritional supplementation, all those different things. And for every 1 point increase in the DR score, we know there's a relative risk of ocular intervention by 28%. And you can see what happens as that number goes up and up and up over time. So just like your visual fields in your glaucoma patients, that you're doing this routinely, probably once a year, maybe more often in the certain patients, same thing here, and watch that number over time. And if you see it go up, you can see what happens to their relative risk of needing ocular intervention in that case. So we'll talk about this at the end. Again, your diabetic, your codes for your patients with diabetes and diabetic retinopathy, here's your most common codes that warrant investigation. Okay. Bradley, anything with this before you take over on the next slide?
Yeah, I would just say I've seen again a couple questions coming across, and really one of the most common questions that I usually get about with diabetes and running the test. Do they have to have diabetic retinopathy? It is true it is not payable with an E11.9 no retinopathy, but as most of us are aware, having diabetic retinopathy does not necessarily mean they don't have another billable diagnosis, whether that be the bottom of their venous engorgement, tortuosity, some form of hemorrhage. We're going to get to slides where we have, so patient has fine drusen and, doesn't have that retinopathy. There are reasons in billable ICD-10s that many times we can find. Doesn't mean that we always can, and we can talk about what we do in that situation, but there are a vast array of billable ICD-10s that are available for use on this test. So I put this case in here just to I guess talk about the benefit of the testing, even if it's someone who maybe doesn't meet that criteria of high risk. This is a patient who, well, I guess my experience with the ERG, we've had the device in multiple clinics for a few years now. We utilize the DR protocol most common. I think anyone who has the device is going to use it for that reason the most. We actually do quite a few PHNR protocols when we're on the fence sometimes in terms of optic nerve pathologies. Are we treating or not treating? In previous webinars, we've done a case where it helped to move the needle in terms of SLT for a patient. So anytime you can have functional data and determine if there's stress on the retinal tissue, there's value in decision making that's going to provide. This particular patient was a 67-year-old white female. Been diabetic and hypertensive for 10 plus years. This is someone who's not incredibly concerned about her condition. We see these individuals all the time. What's your most recent A1C? They don't know, they think it's fine. So just not a great historian, but is diabetic, and so we're watching for those purposes. Systemic medications, oral medications, not any insulin at this time. Ocular data really looks good in terms of functional data. Acuity's fine, pressure's fine, mild cataracts. Did have some scattered dot blot hemorrhages. So by our DRSS standards, that would be moderate, non-proliferative. Did not have any macular edema. So the ICD-10 code that we had classified her level of retinopathy for was below there. The fundus photos are viewed out a little bit. If you can see the dot hemes there, man, you got some good vision, but you just got to trust me on that. She's got some scattered dot hemes. Did not have any DME or CSME. Had a small nevus, but again, pretty standard moderate NPDR without any vision deficits at this point in time. This is a view of the OCT. Again, a few small drusen, but again, nothing that looks like DME. So again, classically, anatomically, really no problem. And then as we do the DR tests, one just based on the presence of the dot blot hemes, but we actually do this on all diabetics. You can see if you jump to the top there, the DR score is great, right? It's in the teens, 17.5. And so mathematically, based on the newest research, we know she's at virtually zero. I think everybody reserves the right to run themselves off the rails in a very short period of time. So I never say never, but based on the data we just talked about, virtually 0% progression for the next 12 months, which is great. But if we look at the actual waveforms, we can see that they're just a little bit slow, right? The implicit time is just a little bit elevated. And you can look at it in terms of the numbers. You can also see it on the pattern to where they fall just a little bit to the right of that normal box. And so what this is telling me is that despite the DR score being normal, right, I'm not overly worried about this individual in the next 6 to 12 months, but there is some retinal stress, right? We've seen anatomical changes based on the scattered dot blot hemes, and now we're demonstrating some functional stress. And so what this creates in my mind, which is maybe the most valuable thing, is an opportunity for intervention by way of patient education, right? We're showing this information to them. We're saying, look, this is not normal. This isn't a 4-alarm fire, but we're on a trajectory that can lead to some vision loss. And so I think when you can demonstrate that, identify and educate the patient. There's value. Also, now we have a baseline, right? So we also know mathematically, as the DR score goes up, how much does their risk increase? This allows us to, have a baseline to compare against. And so it's not 100% the DR score. It's not as simple as you're perfectly okay. I just think we need to utilize this to educate our patients, right? When it's in the teens and not low and slow and quick and strong, like Dr. Nate was saying, great, right? We still tell them, great job. There's value in saying you're doing a good job. Keep it up, right? Sometimes that's as valuable as change. But again, I want to throw this in there just to demonstrate how even if a DR score is normal, it can still present a valuable opportunity for interacting with the patient.
I had a doctor email me just 2 weeks ago, a case very similar to this. The DR score was like 18.9. He said, normal, right? And I said, well, look at it. It's good, but look at it a little bit more closely, and that, you still have to be the doctor and evaluate those waveforms and all of the numbers. But so overall, yes, I like that the DR score is normal, but let's look a little bit closer with some cellular stress here with that implicit time being delayed. So this is such a great case, Bradley. It's just spot on with everything.
Yeah. Basically, we're seeing this individual on a 6-month basis. We're going to repeat the test on a 6-month basis. No problem doing that from a billing perspective with the diagnosis of moderate non-proliferative retinopathy, and we're going to continue to watch the DR score in comparison to where we started to see if we're getting worse or stable.
Yep.
So, Dr. Grant, before we keep going, we have a couple questions in the chat that are related to diabetic retinopathy. So we'll ask first, the high DR scores, how is that changing how you deal with the patient? Does that change what you do next, like see them sooner or repeat other tests more soon?
It certainly does. I would say on a standard, if there's someone that has any level of retinopathy, I'm going to see them in 6 months, whether that's mild, moderate, not proliferative, but if it's something that is not seeing a retinal specialist, I'm seeing them on a 6-month basis. I will either move that up to every 4 months or more often if there is something that is elevated. So if we had a DR score of 27, I would repeat it in 4 months. If we had a DR score of 27 and even the smallest bit of microcystic edema on an OCT, I'm in a practice that's a multidisciplinary setting. We have MDs in the building. I'm probably setting up that next visit with the MD, right? To go ahead and establish that if it's a DR score that has a risk factor of progression within the next 6 months, it's high, and there's associated anatomical changes, I'm sending to my retinal colleagues sooner based on those findings.
Thank you. And then we have another question related to billing and the DR assessment. So when you run this on all diabetic patients, if you don't find a code that's billable, are you billing the patient?
We're billing the insurance, and then depending upon the insurance, if it's non-covered, then the patient will get a bill. Sometimes it goes to deductible, sometimes it's non-covered service. So we don't have the patient pay cash at the time of service. We submit it to the insurance and let the plan details sort that out.
Any other questions, Tori?
We have a glaucoma question that we could answer now or later.
Okay. Let's touch on glaucoma very quickly on the slides, and then we'll answer that question. So, Bradley, I think you have a couple of slides on general retinal health.
Which we've touched I think a lot of these we've touched on. Just there's a lot of different codes that can be billed, not just diabetic. A lot of different protocols: the Flicker 16, the optic nerve, the PHNR. There's a list of different diagnoses, macular pathologies, those types of things. We can assess function there. If we go back one slide there, where I like where it's worded that, what I usually try to mentally compartmentalize for myself is if there's a increase in implicit time, that more equates to stress, retinal stress. If there's a decrease in amplitude, if we're low in terms of the actual production of that waveform, then we have cell death. We're dead and gone, as opposed to just stress. And so again, if you want to think about how does each one of those elements of the waveform get impacted based on atrophy versus stress. That's how I compartmentalize it. And I don't know if you're the same way, Dr. Nate.
So clinically, you could almost maybe argue that which one is more changeable or improvable, it would be implicit time, an abnormal implicit time with better A1C and education and diet and exercise. And, if they control this, we could potentially see an improvement in that cellular stress by that implicit time getting quicker. Correct?
Yep. That's how I think about it. Yep.
Okay. Anything on this slide?
Again, just a list of different conditions that would be good for the Flickr 16 protocol. The next slide starts to touch on the PHNR protocol, which is what we use for ganglion cell analysis. The PHNR report is a little bit different in the sense that instead of looking at a global assessment of waveforms, it actually kind of teases out a single waveform across different levels. So that there's 3 different components to the ERG waveform: the A wave, B wave, and PHNR. A wave being photoreceptor layer response, B wave being the bipolar cells, PHNR being the ganglion cells. And so you can see a report here that really teases out what aspect of the waveform is abnormal. And when we're talking about assessing optic nerve function, we're looking at the ganglion cell layer. And so there's a very nice value that we look at called the W ratio that you can look at the mathematical formula and dive into that as much as you want. But basically, is there asymmetry between the response that's generated by the outer retinal layers versus the inner retinal layers? And when that's the case, it's an isolation of ganglion cell stress, and that reduces the W ratio. So I know we don't want to get too far into the weeds for the purpose of tonight, but basically there is a way that this device can tease out where along the pathway of that retinal response we're seeing the most deficit, and in conditions where you're on the fence about optic nerve pathology, whether it's pallor or ischemia, ischemic optic neuropathy, glaucoma suspects, this really helps to isolate where that stress or damage is potentially coming from. So we use it quite a bit on optic nerve pathology.
This is a great optic nerve pathology tiebreaker, especially in glaucoma, whether you're debating, is this progression, is this not, of looking at, again, photopic negative response, think ganglion cells. So when you're talking protocols, again, DR protocol is the #1 protocol you're going to use for diabetes and diabetic retinopathy. The photopic negative response, or PHNR, I want you to remember to think ganglion cells. That's a ganglion cell function. I bet all of you do ganglion cell structure on your OCTs. So you believe in looking at the ganglion cells, structure with the OCTs, function with the photopic negative response, or PHNR protocol on this device. So you select that protocol, and again, the W ratio, as he exactly said, that's what we're looking for. If it's 11% or less, that's indicating there is change in the specific, and that ratio, and that's really highlighting ganglion cell distress there. So again, that's what we look at again, there's your codes that kind of are linked to this, whether it's glaucomatous optic atrophy, other specified retinal disorders, optic nerve disorders. Again, those are your ICD-10 codes that are tied to that. So let me show you, we're going to finish on a quick case here in just a minute or two. Case that I saw, 32-year-old female referred in for special testing. What's going on in this young patient, 32 years old. She's been diagnosed with glaucoma at 27. At 27 years old, told she has glaucoma. She's been on drops for a while. She stopped her drops. She said, I was tired of my eyes being red, so she stopped her drops 5 months before. Again, when I saw her at 32 years old. Here's her visual acuities. You can see her visual acuities, her IOP history. IOP's running in the low to mid-teens. Low to mid-teens here, central corneal thickness. And now we have, you can see why the optic nerve catches your attention. 32-year-old female. Cupping in the right eye, optic nerve in the right eye, and in the left eye as well. And again, we're looking at 0.75 to 0.9, depending on which eye you look at, horizontal or vertical. Again, certainly the nerves look slightly bigger than average. The cupping looks way bigger than average, but these are going to catch your attention as optic nerves. They're not your standard 0.25 or 0.3 or 0.35. And then the OCT. You take a look at the OCT, ganglion cell analysis in both eyes, retinal nerve fiber layer in both eyes, average RNFL 64 and 61. This is, This structure doesn't look great. This structure doesn't look great either here. It's got red flagged everywhere. But remember that OCT is a statistical deviation from a reference database. That's what that is. It's a statistical deviation from a reference database, and that's why we need to look for progression. As a one snapshot in time, it is a statistical deviation from a reference database. And again, let's get some more data. Visual field. With that degree of change on the OCT, at least suspected change on the OCT, a lot of red there, and yet you have a perfect visual field. The students that day went said, Dr. Nate, could you get much better of a visual field? And said, no, this is as good as it gets. It's perfect. So you're like scratching your head. Visual field is normal. OCT looks like crap. The nerves are just, woo, those are big cups. So let's get some more data. And you take a look at the ERG. And again, interesting here, looking at that W ratio, ganglion cell function, and a W ratio 11% or less is abnormal. And I want the higher the number, the better for the W ratio. And we're looking pretty good in both of these, both right eye and left eye. So again, just a part of our decision-making process to monitor normal W ratio in the PHNR, that with the visual field, the pressures of 13. We just decided to watch this patient. Now we're not going to let her go forever. We're going to bring her back for a 10-2, and we're going to repeat the PHNR and all of this good stuff. But it helped us to monitor. It helped us to just get a little bit more confidence that we can hold on to this in this patient, educate well, but we've got structural testing and functional testing, and there's no perfect test in glaucoma. There's no perfect test in retina. There's no perfect test. We add up all the different pieces and to make the best decision for our patients there. So structure and function, do both. You guys have wonderful structural tests. We have a wonderful functional test with the handheld ERG, the RETeval as well. You got to look at both of them. And there are courses out there by Dr. Chris Wolf. I'm going to leave that right here. And Tori, let's answer some questions.
All right. So we have one here from the chat. So when we're looking at glaucoma and the billable codes, does the diagnosis code have to be established prior to the visit in which that ERG is ordered? So could one of you speak to any potential concerns if you as a doctor have a history of billing under the glaucoma code and then start using optic nerve atrophy?
So established as primary open-angle glaucoma moderate, and then switching it to glaucomatous optic atrophy so that you have a billable code for the ERG, correct?
Bradley, I would add the code to the glaucoma code.
Yeah.
Why can't you code both of them? You continue the glaucoma code, and now you're adding in the optic atrophy code as well.
Yeah, and I think that when you're documenting that in the chart, right, you can detail the results of the ERG in the plan section of the glaucomatous optic atrophy. So I really think I couldn't agree more with Dr. Nate in the sense of, it's not one for the other, but you are adding it for the test.
And Bradley, we still, if you have an abnormal ERG, whether it's the initial one, the second one, or third one, all subsequent ERGs, whether they're diabetic retinopathy protocol, whether they are photopic negative response, all subsequent ERGs can be linked back to the previously abnormal ERG. You do that? We do that in our clinic.
I would do that. I would agree with that. Yes. Yeah.
So.
Yeah, and I think it's just important to note, I mean, the conditions aren't in a vacuum. Most of the time, individuals have multiple conditions. And the CPT code is not different for a PHNR protocol versus a DR versus a Flickr 16. So when you're submitting a claim to insurance, what the insurance carrier is looking at is there a billable diagnosis attached to the 92273? And as long as you document the reason for the test and the findings and attach it to any of the applicable diagnoses, then you're doing what would be asked of from our payers. So if somebody has venous engorgement and I run a PHNR, I can document what I found on the ERG and still bill it under 92273 as long as I have an applicable diagnosis there.
Thank
just
you.
document what the findings were, and you know, that's how you make sure you're doing it right.
Other
So a
questions,
couple other
Tori?
questions, just racing in under the wire here. So if fundus shows no retinopathy, but the ERG is abnormal, so let's say it's a high DR score, maybe it's a delayed implicit time, would you qualify that patient as having DR without retinopathy on the fundus? Would you notify their primary care?
So I'll take a stab at this one first, and Bradley may agree. He may completely disagree on this one. I believe that based on the studies that we covered, in that ophthalmology study, the American Academy of Ophthalmology preferred practice patterns, again, all the literature out there, that if I look at a retina tomorrow and that I see no signs of retinopathy, but yet I run the DR score and it comes back, let's call it 23.7 or 22.4, wherever it is, that I would consider approaching abnormal or abnormal, I would code that that patient has retinopathy at that point. You may disagree with that, and I would respect that, and wouldn't disagree with you disagreeing with that. But I do believe that the presence of an abnormal ERG indicates that they have retinopathy. Maybe it's even subclinically. We can't see it yet, but I would not code diabetes without retinopathy at that point. And again, you may disagree with me on that one, but that's how I would do that. I know that's not historically how you've staged diabetic retinopathy, but I believe in that.
Yeah, I wouldn't disagree with that. I think that I would also say that we're talking about a case that, in some on the call may say this is what I saw, but I don't see that really ever. Most of the time anatomy and function at least correlate a little bit. So it's not like this is an everyday decision you're going to have to make. I would say for me, I would probably look first for a secondary reason to bill it, but I would make a note in the chart that there's abnormal retinal function consistent with retinopathy. But yeah.
And even if you said, all right, I'm not gonna bill that first one because there's no retinopathy, great. You now have an abnormal ERG that you can bill every subsequent ERG to.
Yeah. But yeah, if you start doing this on a frequent basis, and the concern is that you're going to run into elevated DR scores in the absence of anatomical findings, like the sensitivity and specificity of the test is much better than that. So you're very rarely going to run into findings that don't make clinical sense, right? Would be my experience, at least.
Yep. Any other, Tori?
All right, so we are running out of time here. I'm going to select one. Any value for ERG and high myopia to detect potential dystrophies or degenerations?
That's a good question. I'm going to put the high myopia aside for just a second. For detecting retinal dystrophies or degenerations, rod dystrophies, cone dystrophies, rod cone dystrophies, the answer is absolutely yes. If you think that their nighttime poor vision is not just from aging and they're 78 years old, but it's in a younger patient and you're worried about a rod dystrophy, that handheld ERG can do it. Now, we didn't talk about the protocol tonight because the most common protocols you're going to run are the diabetes protocol, the other retinopathies, the Flicker 16, and the photopic negative response for the ganglion cell. But that device is incredibly powerful, and there's like 60 different protocols in there that if you want to dive into the electrodiagnostic weeds, you can. And there are tests that help detect rod function and cone function and different steps along the way. So yeah, if you wanted to detect a retinal dystrophy or retinal degeneration, whether they're in a high myope or not, absolutely, it will tell you, yeah, this retina is not functioning well. It's struggling. So my answer would be yes. Bradley?
Yeah, I would agree. Again, it's a full field ERG. And so you are going to be assessing central retina, mid-peripheral retina, and functional retina. But I think it's also important to remember, just like visual field testing in glaucoma, just like OCT testing, value is gained in progression analysis, right? So don't get too caught up in the first test, right? It's establishing a baseline and watching for change is where I think in those conditions, the value would increase with subsequent testing, just like it does when we do progression analysis for a field in glaucoma. So isolated tests have value. To me, the more that I have historical perspective and progression analysis is where the value is increased.
Anything else, Tori?
Nothing right now.
We're not running it on our 6-year-olds that are -2, though. I will say that.
No,
we're not using it.
Definitely not.
For myopia. Yeah.
Now, if they were -2 that had color vision issues and nighttime vision issues, then you might, right?
Yeah.
And see, is this a early rod cone dystrophy or something like that? So it all depends on the symptoms. So with that, Dr. Grant, pleasure as always sharing the virtual stage with you. I would encourage all of our attendees, if you have the device, keep utilizing it. The more, Bradley, I know you agree with this, the more you utilize it, the more you will appreciate it, correct?
Absolutely. Yeah. And gain confidence in the conversations with patients. There's a little bit of a comfort level learning curve there, describing the testing, but the more you do it, the more it's in your wheelhouse.
Yep. So structure function in your ocular pathology patients, keep doing your OCTs and photos, and add a handheld ERG to that as well. So with that, I wish everybody a great evening. You guys have a good night.